Have you ever wondered why some patients can have surgery to remove a cancer to try to cure it, while others are told that they cannot have surgery or should not have surgery? Have you ever wondered why in some patients who have surgery, the cancer comes back rapidly after the surgery, and in other patients it never comes back? Have you ever had a friend or a relative tell you that you should not have surgery for cancer because opening it up and exposing the cancer to air will make it grow more rapidly? In this video, I will discuss some of the reasons that some patients can have surgery and others cannot, why the cancer comes back after surgery in some patients and others it does not, and why just opening a patient up and exposing the cancer to air does not make it grow more rapidly. My name is Dr. David Stewart. I'm a medical oncologist in Ottawa, Canada, and professor of medicine at the University of Ottawa. And I recently wrote a book intended for patients called A Short Primer on Why Cancer Still Sucks, available through Amazon Books. This is the fourth out of about 16 videos I'll be doing to give my opinion on some things that people have asked me from time to time about cancer. You can get additional details from my book. Importantly, for anything related to your own healthcare, you should rely on your healthcare advisors for advice. Large number of tumor cells may enter the circulation from a growing tumor. On average, there are about 1 million circulating tumor cells for every gram of tumor in the primary tumor. Many of those cells are sick and they die, and that's why surgery or radiation may be capable of curing the cancer, including even very large cancers. But in other cases, some of those tumor cells may lodge in other parts of the body and survive. On average, the bigger a cancer is, the more tumor cells entering the circulation, and the higher the risk or probability that some of those circulating tumor cells will survive in other parts of the body and form incurable metastases. If we cannot see any areas of spread of the cancer on scans, there may truly not be any areas of spread, or on the other hand, there could be millions of very small tumor deposits that are just too small to show up in a scan. If we see just one or two metastases or areas of spread of the cancer, these may really be the only areas of spread, or they may just be the tip of the iceberg, and there may be millions of additional tumor deposits as well that are still too small to be seen. Essentially, the more metastatic deposits we can see, then the higher the probability that there are even far more that we cannot see. Essentially, the bigger a tumor is and the longer it's been present, the higher the probability that there will have been tumor cells that enter the circulation and that will have lodged in different parts of the body to become incurable metastases. For this reason, as a rule, the faster that a cancer can be treated, the better. However, as I said before, sometimes even very small cancers will already have produced incurable metastases before they're found and dealt with. And in other cases, even very large tumors, there may not be any incurable metastases, so they may still be curable. But bottom line, the smaller the cancer is when first found and dealt with, and the higher the probability of cure. Generally, surgery is the most effective way of dealing with a primary cancer to get rid of it and cure it. So a surgeon, though, when they see a patient, they'll make a judgment about whether or not they think that the patient will tolerate the surgery. For example, the patient has very bad heart disease or bad COPD, emphysema, bad kidney disease, etc. Then the surgeon may conclude that the patient would have too high a risk of dying from complications from the surgery, and they would tell the patient that they should not have surgery. So this type of patient would be considered to be what is called medically inoperable. But the good news is, if the cancer is localized, radiotherapy might still be capable of curing that patient, even if they could not undergo surgery. In addition, if the surgeon feels that the patient's quality of life would be seriously impaired by the amount of tissue that would have to be taken out as surgery, then they might conclude the patient should not be operated on. For example, if the patient has emphysema and would require removal of an entire lung to remove a lung cancer, the surgeons might recommend that they not undergo surgery because the patient might then require oxygen after the surgery, and they might require that oxygen for the rest of their life. Whereas a patient with no emphysema and good pulmonary function might tolerate having the lung removed without any problem. So the surgeon will take into consideration the impact of the surgery on the patient's quality of life. Furthermore, if more than just one or two metastases are present, the surgeon might strongly recommend against surgery, since there would be a very high probability that the cancer would show up in other areas later on, so that major surgery with the potential for major complications would not be worth it because it would not be capable of curing the cancer. If a patient has just a few lymph node metastases close to where the primary tumor is, then cure may be very possible by surgery. But if there are several lymph node metastases at a distance from the cancer, a long distance from the cancer, that would greatly increase the probability that there are also very small undetectable metastases in many other parts of the body, so that surgery would not be able to cure the patient. So in that situation, the surgeon might strongly recommend that the patient not undergo surgery. A cancer would also be judged to be inoperable if it's invading into adjacent tissues that could not be removed. So, for example, if it's invading into major blood vessels that could not be repaired at the time of surgery, then the risk of major complications from the surgery would be much too high, and the surgeon would advise the patient not to undergo surgery. But again, radiotherapy might be a reasonable option in that situation. As a rule, when the surgeon does a surgery, they'll take out the cancer itself and an area of normal tissue around it, only because there could be small deposits of cancer that are too small to see invading into surrounding tissues. So if a large enough area is not removed around the cancer, then the cancer could come back in the adjacent area because the tumor cells were already there, but the deposit is just too small to be seen at the time of the surgery. After the surgery, the pathologist will look at the cancer, look at whether it's invading into other areas, and also look for lymph node involvement, because that helps determine the risk of the cancer coming back again in the future. For example, if the pathologist looks and finds that the tumor cells are invading right out to the very edge of where the surgeon cut, that increases the risk that there will also be tumor cells beyond the area that the surgeon cut, and that the cancer could grow back there at a later point in time. So in some patients, if there is cancer growing right to the very edge of the tumor, then there might be a recommendation for what is called adjuvant radiotherapy, where the radiotherapy is given to that adjacent area to try to eradicate any small tumor deposits in that area that cannot be seen. In addition, if the cancer is quite large, or if it's if several lymph nodes, or if any lymph nodes are involved, this would increase the risk that there would also be surviving tumor cells in other parts of the body. That some of those tumor cells that entered the bloodstream and circulated through the body might have lodged in other areas and might have been able to survive in those other areas. So if it's thought that the risk is relatively high, that cancer will show up again later on, then adjuvant chemotherapy or immunotherapy or targeted therapy may be offered. And what this adjuvant treatment is treatment that's given after the surgery to try to kill off any very small tumor deposits that are too small to show up in the scans, but that might show up as incurable metastatic disease at a later point in time. In situations where adjuvant therapies have been found to be helpful, typically they'll increase the chance of cure by about 5 to 15%. So that's not a large amount, but it's some. So that it'd be much better if we could guarantee cure, but we cannot. So what I tell patients, if they're sent to me for consideration of adjuvant treatment, and there's no evidence of any tumor anywhere, I tell them that if I give them adjuvant chemotherapy and they're alive 20 years from now, there'll be no way I'll be able to tell them that the chemotherapy was responsible, because it might have happened just by the surgery by itself. Or if they decide not to take adjuvant treatment and the cancer comes back in a few months or a year or two, there'd be no way that I'd be able to tell them that if only they had taken the adjuvant treatment, that would not have happened. It could still happen. All we can say is that the adjuvant treatment improves the odds a bit by eradicating small tumor deposits that we cannot see in some patients. There's also increasing interest in what's called neoadjuvant treatment, which means giving systemic therapies before surgery is done. And the idea here is it might shrink the cancer and make it easier for it to be removed, and might also kill micrometastases or small metastases before the surgery is ever done. So in most situations, we do not know for sure whether neoadjuvant therapy is better than adjuvant treatment, but there's some situations where it's starting to look like it might be. And so there's some areas that we are now routinely offering neoadjuvant therapy to patients. In addition, there are studies that are being done that show that if you take a blood sample a few weeks after surgery and you can still find tumor DNA circulating in the bloodstream, then that means there's a very high probability there's still residual cancer somewhere in the body that's just too small to be seen, and that the cancer will show up as incurable metastases at some point a few months to a year or two later on. Whereas if one cannot detect any tumor DNA in the bloodstream a few weeks after the surgery, that increases the probability that all the cancer is truly being removed and that the cancer will never show up again. So a lot more research is being done on this, and it could become very important within a short period of time for patients to undergo such blood testing after surgery to determine what the risk is of the cancer recurring again. If there's high risk, then they would get systemic therapies. If there was no detectable DNA found, then they might be advised to not take any adjuvant treatment. Up until now, I've talked about surgery for cure, but surgery might also be done in some patients where cure is not going to be possible, if it's thought that it could help greatly improve the quality of life. An example is if somebody has a colon cancer and it's about to block the bowel, then surgery might be done to remove that cancer to prevent bowel blockage, even if the cancer is known to be widespread and incurable. It could improve the quality of life by removing that tumor deposit. Also, if a patient has severe neurological impairment from a very large tumor deposit in the brain, surgery might be done to remove that tumor deposit, even though the cancer could not be cured, but it could improve the quality of life. Also, if a patient looks like they're at increased risk of a bone breaking, like say their thigh bone breaking because of a large tumor deposit in the thigh bone, then the patient might undergo surgery to place a metal rod in the bone to strengthen it to keep it from breaking, because again, that could greatly improve the patient's quality of life. Again, I said that if there are many metastases, that a cancer is generally not going to be curable. However, if there's just one or two or three, then it might possibly be curable by removing or treating with radiotherapy, all the areas of spread. If there's only a few areas of spread, that's referred to as oligometastases. And it's different than if there are numerous metastases all over the place. So that if just a few metastases show up a year or so after the primary cancer has been removed, there's a fairly high possibility that those may be the only ones that there are no other small ones. Whereas if there are one or two or three metastases that you can see at the time that the primary tumor is first found, then there's a fairly high possibility that those may just be the tip of the iceberg, and there may be far more present. But even then, even if they're present at the time of the initial surgery, it may be reasonable to treat those one or two or three oligometastases with curative intent as well, because they might possibly be the only metastases, and it may be possible to cure the patient. There are also unique situations where presence of multiple metastases may be curable. And the prime example of this is colon cancer metastatic to liver, if the metastases involve just one lobe of the liver. The liver is interesting in that you can remove 80% of the liver and it will grow back for the remaining 20%. Most organs are not like that. But a surgeon can go in and remove the 80% of the liver that the tumor deposits are in, if there are none in the remaining tumor, 20% of the liver, and the liver can grow back, and the patient may never have any further metastatic disease. So one of the few examples of where surgery for multiple metastases may be a reasonable thing to consider. Okay, how about the concern that if you open a patient up and expose the cancer to air, that it will grow faster? This is actually not true. This arose because in the past, before we had CAT scans, we could not tell how much cancer was there. So the surgeon would do surgery. They would do what's called exploratory surgery. So they'd open up to see how much cancer was there, and they might find very extensive cancer that they could not remove. So they would just close the patient up again, and the cancer would continue to grow very rapidly, and the patient would deteriorate markedly within just a few weeks because that was what they were going to do anyway, and the patient would die very shortly after that. So now this is far less common. Because of the scans, we can usually tell whether there's metastatic disease. So far fewer patients are in a situation where they're just open and closed because advanced incurable cancer is found at the time of the surgery. Having said that, surgery can lead to faster growth of very small metastases. And this is because of something called Gompertzian growth. So that as a cancer grows, it starts to run out of nutrients. So it begins to grow more and more slowly. But if you go in and remove a large primary tumor, then that makes more nutrients available to small tumor deposits in other parts of the body, and they may actually grow somewhat faster than they were before. So for that reason, if you're going to give adjuvant chemotherapy after surgery, it's important to begin it fairly soon after surgery. But the key is that we do not know whether those micrometastases are present before or not. And if we do not remove the cancer, then it will become incurable. So it's very important to remove it, because that's the number one way to try to cure the cancer, to get rid of it. And then if the patient's at risk, at a higher risk of developing metastases, then give adjuvant chemotherapy afterwards. It's also important to note that it's not just opening up the patient and removing the primary tumor that increases the risk of or the rate of growth of micrometastases. Radiotherapy also will, because again, the principle is that you're getting rid of this very large tumor deposit, so you're decreasing the risk of or the competition for nutrients, so small tumor deposits can grow faster. But the key is, the most important thing by far, is that we do everything we can to get rid of the primary tumor. And then if the patient is a candidate for adjuvant treatment, then we start those early rather than after a long delay. So for people that cannot undergo surgery, the important thing is that our treatments overall are getting much better, so that we may not be able to cure patients with metastatic disease, but radiotherapy techniques are getting better, overall systemic therapies are getting better. So overall, we're getting better at treating things that may not be curable by surgery. But surgery is still key where it can be done, and where the surgeon feels that the patient will tolerate surgery. On this and other aspects of cancer, if you have more questions, You can check out my book, A Short Primer on Why Cancer Still Sucks, available through Amazon Books, or there are also many other resources available on the internet. So overall, I hope that you found this video helpful and that you think that you've learned something from it. Thank you. Bye.